Hi, it's Justin Shore from Chronicles of EMS with yet another 60-second life-saving tip. Today, learn CPR with a friend. You never know when they'll need it. Forget game night. Forget Tupperware parties. Have a CPR night. Have a CPR party. Contact your local CPR instructors through the AHA. Get them over. Get your friends together. Learn CPR. It's a skill every citizen should have, not just rescuers. So grab the kids' sports roster. Grab your mother's club. Grab your friends. Get them together. Learn CPR, both adult and infant. It's good that you know it, but what if something happens to you? You want your family to know it as well. And also keep in mind that the American Heart Association now recommends 100 compressions per minute when giving CPR. And this can easily be remembered by humming the tune to the Bee Gees, Staying Alive. Until next time, this is Justin Shore with another 60-second life-saving tip.
Pre-hypertension and hypertension and guided them towards managing their blood pressure down. The level of disease prevention that we could manifest in our community would be mind-boggling. We did a Hypertension Sunday in partnership with the Ethnic Health Institute. This is about 3 months ago, where we went to 29 churches, primarily in the core of Oakland, and we did blood pressures on everybody after services. We did 1,200 blood pressures in one morning, and 34% of people were normotensive.
Well, it's after the service. They're a little excited.
A number of people said that. You're not the first one. We've got people who want to design a research study. Let's do the before and service and the after service, and whether we're going to the to the hellfire and damnation place versus the traditional quieter service. But the issue is that we identified a whole bunch of people who 25% of adults in America have hypertension. Half of them don't know it. It's 1 out of 3 in the African American community have hypertension, and half of them don't know it. And I went to a presentation, this is about a month ago, by a researcher at UCSF who's just published 3 articles in the New England Journal of Medicine last fall, really portraying salt as the new tobacco from a public health perspective.
I like that. And
really looking at the amount of salt in food and its contribution to hypertension. And she just made such a compelling argument that you can very easily coach people to some day-to-day behavior strategies that don't require them to go get medicine. They don't have to go for an MRI or a sleep research. I don't have to go through any of that kind of stuff. Blood pressure's high. Coach them on cutting down the salt in their food.
Even just learning how to not just read the package, but interpret it.
Exactly.
Percentage daily value of what else are you eating? That's something I try to do, and I'm sure Mark does, and a lot of the folks that follow us, is you try to make those little interventions. Whenever I have the patient I call Irma Fish Biscuit, she's in her 80s, she's on 15 medications from 14 different doctors.
Yeah, absolutely.
She's not feeling well. Well, we look around for visual cues, but I'll go and check the fridge. She's got fresh groceries, but she doesn't have a car, she doesn't walk. Somebody's coming by that house to watch after her. What's going wrong? And it's taking those little steps and trying to put together the whole picture. But it all comes down to, well, now I have to take her to the emergency room, where goodness knows what she's going to contract while she's there. It's going to make her sicker, perhaps.
Yeah, I think one of the most profound things that a nurse friend of mine stated was that the hospital is not the place to heal.
No.
And it's quite true. Having done my share of stays in the hospital for medical injuries and so forth, it's absolutely not. You never get any sleep. The nurse has to come in and do their job and take your blood pressure and so forth nonstop. You're open up to just a profound amount of diseases that you've never even heard of that have more than like 20 syllables. So definitely, we need to keep these people out of the hospital, especially the elderly, just for their own well-being.
So how do you make that step? Is that where you come in, what you were saying before? There's been so many good ideas around the table and so many good starts and stuff, but how is it ever going to move from here to there?
It's preventing the 911 call in the first place.
Yes.
So
once 911 has been called,
education.
it's too late. So that if you've got asthma, most people have a controller medication and a rescue medication. 90% of people don't know how to use their inhalers. They don't know the difference between their maintenance inhaler and their rescue inhaler. People with the rescue inhalers, most of them don't use the spacer. Spacer increases the delivery of medication by 30%. They've got spacers that are small enough now you can carry it in your pocket. 70% of the healthcare dollars spent in America are spent for people with chronic disease. And most people with chronic disease don't interact with the healthcare system until they haven't been taking care of themselves very well for a while.
Too far behind.
So building the community's capacity to care for each other, one of the other programs we're working on is we're creating community health advocates. We're working with an organization called Youth Uprising, which is in one of the tougher neighborhoods in our community. It's right next to Castlemont High School, which for years had been considered the most violent high school in our service area. And they've got 4,700 youth members between 14 and 24 years old, and they've got a gazillion programs for them. But one of the things we're working to do is to build education so that, I know a little bit about asthma, or I know a little bit about diabetes. So if I've got a friend who's got diabetes, and I'll say, hey, Justin, did you take your medication walking to school in the morning? Did you take your medication this morning? Yeah, I took my medication. Have you had breakfast yet? You haven't had breakfast? Let's stop and get a banana. You got to eat after you take your medication. I know that much about it. So it's just enough to get started. Also, safe sex practices, conflict resolution practices.
CPR?
CPR, we'll have them be CPR instructors. We're doing the CPR 7 program. We're training all 7th graders in Alameda County to be CPR instructors with their own friends and family kit. That program just kicked off last week. So we've got a number of things going from that perspective, but the ability to build the community's capacity to take care of itself, rather than relying on the system to do it for them.
Do you personally see, would you like to see the medic role develop into respond, treat, leave, or refer, or anything like that? Or what you said at the beginning about the educational needs and stuff, is that always going to be out of reach?
And I'm going to answer your question kind of by not answering your question.
Yeah.
I know it shocks many of you at the table. And that is, my focus isn't on what the medic's going to do. My focus is really on what does the patient need. And I think as medics, we have a unique role in the community. We're trusted in people's homes. We're clinical professionals. We are distributed. We understand supply and demand in ways that a lot of folks don't. We've got the ability to administer tests. We've got the ability to follow protocols. We've got the ability to connect people in systems. So I think we play a pivotal role. But there are some things that, hey, it may be that the best thing we can do is talk liquor stores in communities where there are no grocery stores into stocking milk, apples, and fruit next to their potato chips and onion dip.
But with you saying it's not what the medic can do, but what the patient wants.
What the patient needs.
What the patient needs, yeah. But the medic is ideally suited to help them in that decision.
Don't disagree with you. Don't disagree with you. And do I see the role of medics evolving? Absolutely. But it's a question of focus, because I've spent time with folks who are really excited about building community paramedic programs, and I think that's a great idea. I've taken a different approach to it, because over 37 years in this business, I've seen a lot of great ideas that people have come up with and developed things for, and then run around and look for a place to put them.
Yeah.
I was at one place where you drove around the community, and all the kids on tricycles and skateboards had these really cool helmets on. Turned out there was an EMS program to distribute helmets for kids.
Cool helmets.
And cool helmets. Kids loved it. You weren't cool if you didn't have one on. I thought it was a great program, and I just said, wow, how many head injuries have you prevented with this? Well, we didn't really have any head injuries before this. So and it's cool, and I think it's worthwhile and all that kind of stuff. But it's this elaborate program that people put a ton of money and energy into, that was to address a problem that didn't exist. As far as the data goes, at least. From an asthma perspective, we've got communities in West Oakland where 25 to 30% of the adults have asthma. It's through the roof.
Yeah.
I
see what you're doing is fantastic. I hope it's not coming across that.
No.
It's like you should be letting your paramedics respond and
I hope you don't think I'm dissing paramedics.
But imagine how great it would be in an ideal world with the finite resources and more staff if you could do all of your community outreach programs and stuff, and then have the paramedics who capable and able and trained to do that, it would change the landscape of healthcare within that area.
And change the career path for paramedics.
Yes.
I mean, people as they get older, as their backs get hurt. I mean, I'm absolutely in favor of building a richer, robust career for us along the way.
I hope not to be carrying people down the stairs when I'm 59, well, 65. I've got to work too. Figure that.
One real quick issue I want to touch on. Great community programs like this often begin at the treatment level with paramedics, firefighters, EMTs, whoever it is. In a lot of communities, there's private EMS providers that are going through a lot of flux. You might develop a program with, like where I worked in New Mexico, Albuquerque Ambulance is the sole provider there, but there's other companies starting to come in.
I like those guys.
Great, out of Presbyterian. If Albuquerque Ambulance and the people that work there develop a great program, but then another agency is going to come in and administer the care there, how can I, as a paramedic that's part of this program, make it beneficial enough so that it will stay when the new provider comes in?
You know, that's an interesting challenge, and certainly one I'm very much in the middle of right at this point in time. And my sense is that programs like this don't survive without a serious champion. And there has to be somebody who eats it, sleeps it, dreams it, you know, blogs about it, comes on shows like this about it, you know, and really focuses on it and is committed to staying in the community no matter who their boss is or no matter what name is on the side of that ambulance they happen to be working in. That it has to be strong enough in order to be able to survive that transition. And I've got some great folks who are really passionate about this kind of stuff. I do have some concerns because a lot of this is stuff I've been writing about for years, and when I got the job in Alameda County, it's like, oh, they gave me this big laboratory that I get to play with all these things I've been writing about and teaching about for years.
Not to say that one company wouldn't come in and replace another and, you know, start from scratch. Okay, everybody, we're going to be EMT basics and go from there and we'll see how you do type of thing. Not to make, I don't want to make new companies the bad guy. There's some old companies out there that are not all that into what you're doing, but I'm trying to think about the chat room, the folks that might be watching this and saying, I want to start an asthma program, but my company's coming up for bid for a year. Should I wait or should I do it?
I would respond to that in many ways. Just my 2 bits on that is that if the program itself, like Mike's created, it has to become part of the culture of the system as a whole. Not just, this can't just be an AMR program. It has to be a Alameda County program. And so the thing with good ideas and everything else, it's like, you know, we're not going to do anything, you know, about this until we find out. But, you know, until we find out, you know, the new company comes, whatever. You know, that's just stalling progress. I view it that way. I believe that if you have an idea and you want to move it forward, that you need to go ahead and begin that process now. Now's the time, because that delay, if we've seen it before, delays can be set delays. And next thing you know, it's 10 years later and you're 69, you're retired. 65 and you're done.
69.
You know, 69. That's just too much. Yeah. But so as far as that goes, I would advocate I believe that, I mean, Mike's asthma program right now is just, it's very profound. And I would advocate that the Alameda County Public Health Department, the EMS agency, make it part of their government response, you know, as far as that, to support that in itself. Absolutely. Because that then, it becomes an ingrained part of Alameda County within itself, and it has that support. You know, it's listed down as a policy in there. And for those that are out there within the community that have other programs such as that, it's about building your network and establishing that, a transition process, a just in case, a fallback to make sure that the program is stewarded.
And I would, to chime on answering your questions, everything that's cool in EMS started with somebody who, I think Tom Peters used the phrase, a monomaniac with a mission, who was willing to blast through whatever obstacles. I mean, we wouldn't have jobs as paramedics if somebody before us didn't, you know, fight all those battles about, you know, people that aren't doctors can't intubate. I mean, you know, there was a whole pile of things that were, you know, blasted through incredible obstacles in order for us to have a profession that we do today. So if there's somebody who's out there who's listening who's got a notion that they're passionate about something, they have an actual need for it in their community. And I mean, you know, every community has got issues with diabetes. Every community has got issues with falls, elderly falls. Every community has got issues with hypertension and hypertension-related diseases. Asthma is very common. You know, if you find something that you really love and that you care about, I've actually got a couple of folks who are very interested in the whole issue of sepsis and early identification of sepsis, and we're actually developing a pilot for being able to do sepsis alerts the same way we do STEMI alerts and stroke alerts. It's the folks in Littleton, Colorado are the folks who really kind of pioneered this, but we're looking at kind of following along with it. And I've got one of my longtime medics, her mother died from sepsis. So when I first mentioned this as a possibility, she's already done 130 hours worth of research. She's got every study that's ever been published on sepsis in the last 25 years. She's outlined them, she's distilled them, and this is her baby. And to just kind of, you know, my job is to kind of pull barriers out of her way and, you know, keep feeding her and encourage her to continue. But it takes somebody who gets it, who's got enough tenacity to get through the crap to make it real.
And let me kind of sum up with this. It sounds like our mission is public health, but our funding is in public safety. Where do you guys see EMS falling, or should we be in those rigid models?
Well, see, this is
Public health or public safety?
Wow, is that just a,
yes or no?
Can you take that sucky question back?
Is that just a quick one to finish off with?
I think. I think overall, this is where we come back to organizing and collaborating and unifying together EMS to build that larger agency that provides us with a voice and access to large amounts of grant funding to proceed forward. Because right now, you're right. Where we're at right now is we're public health kinda, but we really kinda don't fit into security right there. We're right here in the middle. That's why we have to be our own entity. That's why we have to go ahead and basically support ourselves with an agency represented at the larger federal level, national level, to go ahead and be, so we're not security, we are a part of public health, but we are EMS, we are emergency medical services. And I think that's where I feel that, I mean, it's no doubt, we're headed that way, we're going that way, the profession is going to evolve. You know, we're gonna find the solutions that are there. It's not that they're not there or we don't know what to do. No, they are there. We just have to develop them and enact them. That's it. You know, and move that forward. So to answer your question very poorly, your bad question is overall is that we need to be our own entity. We need to have an EMS agency that represents us all the way to the president. And then it'll come down and branch out into the states, into the counties, into the local jurisdictions.
Federal funding for community solutions.
Absolutely.
I like it. Mike, your thoughts?
My thoughts is it's a very overlapped Venn diagram, and again, when you look at it from a patient perspective, patients have public safety needs. You know, if somebody in my neighborhood is shooting, when I call, I'd like the police to come. If there's a fire in my neighbor's house, I want somebody who can put that fire out to be able to be there and be there quickly. If you know my dad has chest pain, I want medical services to come there quickly, and all of this may be wrapped up in social services needs and all kinds of other issues. So I really think that when you look at it from the perspective of patients and community, that there are all these kind of circles of systems with public safety and all the branches of public safety. There is funding, there's all the other government infrastructures that are essential for trash pickup, and I mean, the minute you think that essential services are police, fire, and EMS, go to a city that has a trash strike sometime, and you realize, you know, all the other vital services that are necessary in order for a community to exist and function. And I'm a huge fan of really soft, porous walls, as opposed to a rigid line between things.
Yeah. So, third service, on our own. Step out, branch out, EMS-based EMS.
Yes. With porous walls.
With porous walls.
With porous walls.
And no trash.
And no trash.
No trash.
Exactly. That'll be a long step. Well, anything else you want to add, Mark? Anything from the chat room?
No, the chat room there just discussing everything about community medicine itself, and there's 3 or 4 of them in there just going backwards and forwards. And we've got the Smurfs, who's a guy from Dublin in Ireland, and he's having a very good back and forwards with a couple of the American guys. So
I've loved all my trips to Dublin. It's a favorite place to land.
Yeah, oh, you like that.
It's a great town.